on the PDF. Yeah, I think this might be the third time of doing a virtual presentation like this. I've been at OHSU since 1990 and a PT since 1986, and I have done a variety of things in physical therapy, and most recently focused on women's health and pelvic health. I volunteer and teach with the Academy of Pelvic Health in obstetrics, and developing course curriculum in obstetrics, and then gender affirming care, and then also electrical stimulation or neuromodulation. These are like we're talking in an hour about pelvic health in a general rehab. So, and you can take 9, 12, 15 days of coursework to learn about different scenarios of pelvic health. So this is very much an overview. I think there are some new people here, and if you've seen this before, we're maybe getting some intentional reinforcement with some of the parameters. Somebody has a mic on. Somebody, I'm gonna turn, yeah, everyone needs to turn off their mics. That's okay. Okay. So we're going to talk about evaluation and treatment, and we're going to be primarily focused on bowel and bladder function, which can sometimes contribute to pain for people. But lots of the same pain principles that you've learned from some of the other coursework that you've done here can apply in pelvic and abdominal pain for the skill set that you are already trained to deliver. Last year, people wanted ways to have effective communication, and I'm going to say the best thing that you can do is have lots of pictures and models of the digestive system, the urinary system, the bladder. I have this illustration here of the hip muscles because there's a lot of interrelationship there, and then specifically pelvic floor muscles and the nervous system. And that can be really helpful. And if you want me to share more with Connie, you can direct it to Connie, and we can talk about places that you could get models. This is something that you're seriously interested in doing more of, and educating patients why you're talking about their hip muscles, or where their digestive system is and why this massage matters in this way. I have a key here where if you see these little icons at the bottom of the slides that you have, it's indicating this would be an appropriate treatment for a female person, a male person, someone who's elderly, someone who is pregnant, somebody who has a neurologic condition, a pediatric patient, and then this null sign would indicate don't use it on that patient population. Primarily, we're dealing with the pelvic muscles, and something I learned this summer in talking with Connie is it's not something that's integrated into physical therapy in Thailand right now. So I'm not going to focus a great deal on the specific pelvic muscles part, but talk about how you can do other things to affect the pelvic floor muscles. We'll talk about abdominals, hip muscles, and then also the respiratory diaphragm, so the top of the abdominal cavity. We'll touch it here. We'll talk about a little bit about positions for toileting in pelvic health. We'll also talk about positions for sexual activity and other activities. Manual therapy can be in the joints, muscles, and nerves, but primarily we're going to focus on the ways to do bowel massage, and that a caregiver or the patient themselves could be taught to do the bowel massage. I will do EMG biofeedback, electrical stimulation. This includes some of the stimulation that was learned by people who came here this summer and fall to affect bowel and bladder function with transcutaneous tibial nerve stimulation, and then also some things on the abdomen. I'm going to ask that someone turn off their mic again. Thank you. So it's very distracting. Jenny, your mic is on. So pelvic muscles, again, I generally look at and touch the pelvic and perineal muscles or use small electrodes for the EMG. And then I have a lot of training in doing internal pelvic floor muscle exam, but again, we're not focusing on that. For your perspective, and I know you work with a wide degree of patients, like sometimes people have accidental loss of urine or stool because it's too difficult to undo their clothing, or they're walking slower to the toilet than they used to, or they have difficulty transferring. So all of those things are going to be important for you to acknowledge. Just this past week, I had a patient I was seeing, and none of the physician notes ahead of her coming to me mentioned that she was in a wheelchair all the time, and that was her primary mode of ambulation. And I think you can imagine that that could have some impact on her pelvic floor. Generally, for diet, we really influence that people or want to influence that people get multiple servings of fruits and vegetables per day with a target of 35 grams of fiber, about 50 to 80 ounces of non-irritating fluid. So primarily this is water and juices. We're going to talk about their hobbies and how long do they do their exercise, or how long are they seated playing video games? When do those things occur? And then some specific considerations based on the diagnosis. When talking about children, they're generally, you want their fluid to, most of their fluid to come from things that they're drinking. Again, water, juice, and milk are common here. Somewhere around a quart or a liter or just above if you're dealing with a younger group like 4 to 8-year-olds. And then when they're in their tween years, closer to 1.5 liters. And boys tend to, we encourage them to drink more. And then just talking about, I'll usually say like a serving of fruits or vegetable is the size of your fist. We generally talk about if people are, particularly if people are having bladder issues, avoiding caffeine or avoiding beverages that are high in citrus. These days, you know, I'll ask people to avoid it, and if avoiding it doesn't change any of their symptoms, then I will say, you know what, if you want to add it back in because it has other benefits to your life, you can do that. Artificial sweeteners, so things like sorbitol, xylitol, saccharin, those do change in the gut and the bladder. So we really encourage avoiding that. And then talking to people, do they have other allergies to gluten, dairy, sugar, or wheat? When people are urinating, sometimes we'll have people measure the urine. There's something that we use called the hat to measure that. And in an adult, you're wanting their output to be around 8 ounces to 16 ounces, so 1 to 2 cups each time they void. And the total is you're looking at 6 cups daily, and it should be pale yellow. It is not always easy for people to measure, so particularly thinking about the coordination and the vision for doing that for people who are older or people who have had some neurologic impairment. Generally, we're looking for people to urinate about 5 to 8 times during the time they're awake. If they're under the age of 65, waking 1 time at night is acceptable, and over the age of 65, waking twice at night is an acceptable number. Some of the antidiuretic hormones that we produce at night slow down as people age, and so people, and we use this cutoff of over the age of 65, generally produce less antidiuretic hormones, so they make more urine at night, and that's the reason for that difference. When talking about urine, you can print things from the internet that show urine color, and so this is that pale yellow. I have Post-it notes. They're actually lighter than how this photo is showing, where this would be a desirable urine color, and this is a little bit more saturated, indicating that there's some dehydration, which can also affect bowels as well. children, again, their daily volume of urination, if they weigh about 50 pounds, is going to be about 2.5 cups. And I put the metric conversion there. So about 23 kilograms would be equal to them urinating 600 milliliters. And then it really is just double. So it's weight based when you're talking in that age group. Sometimes it's difficult for people to answer the questions about bowel and bladder and when are they drinking, what are they drinking, how often are they urinating, when are they having accidents. There are bladder diaries, and you have some of the links to them there and the illustrations. This is a very complex bladder diary. People are entering what happens every hour of the day. So generally waking at 6 a.m., what did they drink? What was the volume of it? How often did they go to the bathroom within that hour? Did they have any leaks within that hour? Did you have a strong urge to urinate prior to the leakage or prior to going? And then was there an activity you were doing? 1 to 3 days of a bladder diary that is this complex is sufficient. Tracking this much information longer than 3 days does not work well for most people. And if there's missing data, all of the data becomes unhelpful because you really don't know, were they drinking enough? Were they urinating enough? What, were there any leaks? Some simpler versions are just breaking the, like what happened in the morning? What was important to you? Did you have any accidents upon waking? What happened around breakfast time? So a little bit more simple. So in the other illustration, 1 page was a day of information. Here, 1 page is a week of information. I will also sometimes, and I encourage a lot of people to do this, like, all right, let's talk about what happens during the day, what happens at night on the thing that is most important to you. So I see children, sometimes children have accidents of urine during the day, sometimes they have it at night, and just tracking those things. And then what is the most important one that they want to change? Maybe they want to go to a sleepover, and so being dry at night is more important. And then this is really just me asking the patient, what is the most important thing to you that you want to see change about the problems you're having with your bowel and bladder? And let's track those things. You'll see this illustration coming up again. If they're tracking bowel, I'll usually give them a copy of the Bristol stool chart. Bristol stool chart is also helpful for kind of guiding dietary choices or fluid choices. Coming back to bladder a little bit. So now we're going to talk about urinary leakage, and we're breaking it down to the 2 most common parts. So urgency leakage is when the bladder is signaling that it's time to go and the rest of the nervous system either amplifies that too much or the rest of the nervous system gives up and lets the urine leak. Urge-related leakage can be a large amount or the whole bladder emptying. It is generally something that is driven by the internal environment and the autonomic nervous system because the bladder isn't under direct voluntary control. Stress, which this is sometimes complicated for people because in English, stress is like a physical stress, but we also use it a lot to describe mental stress. And mental stress influences urinary urgency. So here we're talking about physical stress. It's usually some part of the skeletal system. The muscles of the pelvic floor aren't strong enough to, if somebody coughs or sneezes or lifts or jumps, they're not strong enough to combat what is happening from above. And that is how leakage occurs. I have an animation coming up showing that's like the urinary urgency, the bladder spasming. And the treatments are a little bit different for those. Both would include some activation of the pelvic floor, which you'll see in the slides coming up. but the urgency, we can do some other calming techniques. For bowel, it is normal for people to poop 3 times a day. It is normal for people to have a bowel movement only every other day or 3 times weekly. We expect that people will never have leakage of stool, so that number should be 0. Sometimes your bowel leakage can be related to urgency. Sometimes it can be related to constipation, where some liquid stool kind of slips out behind the firm stool. And talking about pain, again, specific to kind of like pelvic health, but not really all pelvic floor, really kind of drilling down on where is the location of the pain, when did it start, and what are some specific provoking activities. So you've learned in some of your other coursework about like, it's running, it's lifting, it's reaching overhead, it's bending over. Here we're looking for things that are happening in the urinary system or the digestive system or the reproductive system in females. Is their pain related to their menstrual cycle? And then what helps it go less, and how long does it take for the pain to reduce? I included this image in here this time. I'm not going to go through every visceral referral. Hopefully you've learned some of this before in a differential diagnosis. I often like to point out to other students that I teach how broad the referral of the kidney is. Basically the low back and into the lateral thigh, also into the medial thigh and below the umbilicus. So we need to remember that abdominal and pelvic pain can have a visceral origin. There are ways to do an abdominal exam. Some of the physiatrists or physicians here might know this, just like palpating the organs. And then we also do something called Carnet's sign, which is a way like if you palpate on the abdomen and there's pain in the right lower quadrant, and if the person lifts their head and activates their abdominal muscles, if the pain goes away, that tends to indicate that what you were palpating and what was the nociceptive input to their pain was a visceral structure. If the pain worsens or stays the same, then we're saying, well, it was the abdominal muscle wall because you're still in contact with the abdominal muscle wall. When talking about the hip, it's important in low back pain in non-pregnant people, low back pain in pregnant people, and hip muscle weakness is associated with both stress urinary incontinence and urge urinary incontinence and pelvic pain. So as I said, I learned earlier this year that pelvic floor PT and pelvic floor exams aren't something that is integrated into what is happening in Thailand right now. And I bring up this information because there's still a lot you can do to help your patients by doing great hip exams, great strength exams, and giving them really good exercises for these areas. Particularly, we're talking about the obturator internus. This illustration shows that it attaches onto the greater trochanter of the femur. And this illustration is showing how it is the attachment point of the levator ani or pelvic floor muscle group. And that is, again, just a different view showing how it originates in the inside of the pelvis and then goes onto the greater trochanter through the outside. We're now going to get into some treatment principles. We're going to focus on stress, so somatic nervous system, nocturia, and then urge-related leakage, and constipation. And nocturia is that waking at night more than the 1 or 2 times based on their age. Some really simple things, all the things I told you about evaluation and asking questions, like if they weren't doing it, not eating enough fiber, not drinking enough fluid, now is your opportunity to educate them on doing that. And distributing that fluid intake throughout the day Sometimes when people drink a large amount of fluid at once, it's processed by the kidneys and made into urine, but it's not available to keep the stool consistency right. So this fluid should be throughout the day. And avoiding those irritants and providing alternatives for that. So non-citrus beverages are good, non-carbonated water. And then for people who drink coffee, there are things like kava and Ovaltine that are less acidic and less caffeinated. So this is for bowel and bladder, all of those things I talked about. For stress urinary incontinence, our focus is really on strengthening the pelvic floor and the muscles surrounding the pelvic floor. The number of pelvic floor contractions to do, or as we talk about some of the ways you can get an overflow response for people to contract the pelvic floor. Generally, a slow contraction lasts anywhere from 5 to 10 seconds. When people have leakage with coughing and sneezing, sometimes it's good to practice some fast on and off contractions. And there should be an adequate rest time. So if people do a 5-second contraction for their slow contraction, they should do at least a 5-second contraction, a 5-second rest for that period. If they're doing 10 seconds of contraction, give them 10 seconds of rest. And then, so the recovery time matters. Generally, this study found that 9 repetitions per session was good, and the recovery between sets of exercises should be 1 to 3 minutes. So if people did 9 repetitions of a 5-second contraction, then they would rest for 1 to 3 minutes, and they could repeat that 2 to 3 times. And it will take 6 weeks for there to be a visible change. If you need to increase the intensity of the exercises, you can ask people to increase the number of contractions, how long they hold the contraction. So if they were doing 5 seconds, they could now do 10 seconds, how many fast contractions they do. And there are vaginal cones of different weights, and they could also use biofeedback, and they could do their exercises in lying on their back, sitting, or standing, and maybe even some quadruped positions. One of the ways I facilitate pelvic floor contractions in practice is to have people exhale with a restricted exit, so through a straw or making a shh sound. The respiratory diaphragm relaxes during the exhalation, and the pelvic floor is one of the muscles of exhalation. So you're going to see those red arches change position. So during the exhale, the pelvic floor contracts. And urinary leakage is common with coughing and sneezing and stress urinary incontinence. And coughing and sneezing is a rapid exhalation. So training the pelvic floor to contract with exhalation can help. You can also have them practice doing a pelvic floor exercise with coughing and sneezing. We're going to talk a little bit about how activating some of the muscles of the feet can facilitate pelvic floor muscle contractions. This can be related to the fact that the innervation to the pelvic floor comes from the lower sacral segments, as does the innervation to the intrinsic muscles of the feet, the gastroc, a little bit of the anterior tib. So getting activation in those muscles. Also, it's not as well illustrated here, but on the motor homunculus, the toes and genitals are represented in a similar location on the brain, so they tend to map together. Some of the exercises that people can do, they could do a toe stand or a heel raise. You could have them hold that for 5 to 10 seconds and then rest between. I mentioned that I see pediatric patients. I am not doing internal pelvic floor muscle examinations, nor am I commonly doing external. This is a way that I can cue them to attend to their pelvic floor and abdominal muscles. There is also some data that shows standing on your heels will facilitate a pelvic floor and lower abdominal contraction. So these are simple things that can be done. Hip strengthening. So I talked about that relationship of the obturator internus and the pelvic floor. We know that bridging and supine planks can, when done properly, facilitate activity in the lateral hip abductors. We also know from some studies that looked at ultrasound on the pelvic floor that this also facilitates pelvic floor muscle contractions. They looked at the genital hiatus and it was smaller during these exercises. And this is a person doing a standing hip abduction. Maybe you're having patients do these exercises for balance and safety with walking. You can cue a little bit more of the pelvic floor if this person also has urinary issues. Kind of talking about balance. So waking at night, if we just say like, oh, more than 3 times, that's inconvenient. But it also precipitates a fall risk because it is dark and people are tired and maybe they're not wearing their glasses. So reducing nighttime waking to urinate also reduces people's fall risk. So it's not that people only have balance problems or only have pain problems or only have bladder problems. They can be linked together, and you get to provide the best care when you can give them solutions that are simple and affect multiple things. So for nocturia, some of the simple things to consider are, we generally say avoid drinking fluids after 6 p.m. And that is also sometimes stated as stop drinking fluid about 3 hours before bedtime. People can lie down and elevate their legs in the air, and we are just using gravity to what we say mobilize third space fluid. So the interstitial space, you were all talking about lymphedema a little bit earlier. We're just trying to promote that interstitial fluid entering the lymphatics and vascular system and being processed into urine before the person goes to bed so they can empty their bladder and be woken less at night. We do have to remember that sleep apnea and other conditions will contribute to people waking at night, and those should be medically managed. Similar cardiovascular disease or medications they're taking for their cardiovascular disease. If they're taking diuretics in the evening, that might be contributing to some of their waking at night, and that is something that should be managed with the prescribing provider. The exercises that we talk about are just lying on their back, feet slightly elevated. People can do a straight leg raise, a quad set, ankle pumps, heel slide, bridging, and then lower trunk rotation. You know, sitting in a chair with the legs up isn't enough. The head, heart, and kidneys need to be below the legs. Now we're moving on to urinary urgency and urge incontinence. There's a component of, remember I talked about the all things, and so we talked about fluid intake and bladder irritant, so we're already kind of managed that in my earlier conversation. There's a combination of urinary urgency. You'll oftentimes see it described as the bladder squeezing, the bladder's the problem, the bladder needs to calm down. It's an interaction between the bladder and the brain throughout the nervous system. So there are some behavioral interventions that need to happen, breaking some habits that people have established over time. And then also we can use TENS in this application. So some of the behavioral things are making sure that people sit when they sit on the toilet or when they sit to urinate, that they empty completely. I'm going to jump into and creating a bladder schedule. So if they know that they leak, if they put off urination for 3 hours, then they should have a bladder schedule that they urinate every 2.5 hours. Coming back to this challenges to key and door leakage. So key and door leakage is sometimes described as a neurotag. Your brain and system has figured out that when you get home from work or school and you put the key in the door, or you bend over to untie your shoes, the next thing you're going to do is empty your bladder. And so what the whole nervous system does is it just speeds up that interval, so the bladder begins to squeeze, and if the pelvic floor isn't on guard and closing it, that contributes to that urgency leakage. So it's not a bladder problem, it's an association problem. And so I will sometimes have people like use the toilet to urinate, wash their hands, and then leave the house and come back to the house or apartment and not go to the toilet. Like, don't associate that. I will also have people like, again, use the toilet, empty your bladder, it's empty, wash your hands, leave, and 5 minutes later, come back into the bathroom and wash your hands. But do not respond to the interpretation that you need to urinate. It's just a pattern that the brain has recognized. And that can be a complicated thing to teach, but it can really make a big difference. Some of these pictures should look familiar to you because I told you you could use a heel raise or toe stand and a heel stand or toe taps to facilitate pelvic floor muscle contractions. They can also be used to suppress the bladder urgency. There's only one study that looked at this, but they had pretty good results on the people's sensation that they had to urinate and also on the bladder contractions. It can be done in sitting. It can be done in lying as well. So people who wake in the middle of the night could calm the bladder so they're not rushing to the toilet by just doing some ankle pumps. But this is an urge suppression technique. It's done in the moment that it's needed, and that's contrasting it to how I told you could use these activities for muscle activation. When we're talking about neuromodulation or TENS, you would not use it on a pregnant person. You would not use it on a person who has a pacemaker. Somebody who has some cognitive impairment, you really want to be mindful that the communication process is clear. It has been studied in pain and bowel and bladder conditions, both of difficulty emptying and emptying too readily. The connection, if I haven't shown you this image enough, is again about how the nervous system and the nerves to the pelvic floor originate through sacral roots 2, 3, and 4, as do the components of the tibial nerve, where this is most commonly studied. If you were here this summer and with the stroke group, we also talked about, and we're talking about doing it just anterior and on the fibular head. If you were in the dementia group, we didn't do this because it really requires a lot of cognition and feedback to do that. So if you were here for the stroke group, we talked about the anterior portion of the lower leg near the fibular head on the common fibular nerve. It should be the TENS unit should not be modulated. The frequency should be fixed anywhere between 5 and 20 hertz, so it's not changing. And the pulse width is commonly done between 200 and 400 microseconds. For my pediatric patients and people who are nervous, I will go lower. The intensity should be strong, not painful. It's usually done 30 minutes. 1 to 3 times a week. People usually have a home unit here, and the treatment period is usually there should be some change in their urinary urgency within that 12-week period. Again, here's the common placement on the tibial nerve. It can also be on the low back. These could be a little bit lower, kind of closer to S3. And for people who have problems with neuropathy in their feet or awkward to get to the back, you can also place it suprapubically. I am going to talk a little bit about pain, but I hope that you have gotten some of that education already. I think a lot of people think that pain and the pelvic floor requires a lot of manual therapy and internal work. And if you read some publications, that is what they will say. And the most common one is this Fitzgerald from 2009. I just am pulling this up. I'm not going to talk in detail about it, but just the contrast that they didn't have a group that got manual treatment and a group that got exercise. They had a group that got manual treatment and exercise and a group that got general massage. And this group on the left had more benefit, but we can't really state as to whether that benefit was from the manual treatment or the exercises. So I just want you to feel comfortable that if you're working with people that have pelvic pain and you don't have that knowledge or ability to do some of the internal work, you can affect a lot of change with your exercise program. There's also a lot of incorrect information out there that pelvic floor exercises will increase pain in people who have pain or urinary complications. There was one study based on 2 people who did the exercises on their own who had some worsening of their symptoms. There are multiple studies that show exercising the pelvic floor reduces the pain symptoms, and we know that from other areas of the body as well. I like to have people do things like child's pose or happy baby, some things for stretching the hip and low back, and some of those same breathing exercises focusing on a nice inhalation. We are going to come back to slides that you're like, she keeps putting the same slides in. It's very intentional. So I told you that urge urinary incontinence is linked to weak hip abductors and weak external rotation, as is pelvic floor pain. So some of the same exercises that you did could be helpful. Okay, we're moving on to bowel function now, and ways to improve bowel function. People need to sleep well. People need to move and exercise. I'll show you some simple exercises, but walking is really great. And then we can talk about positioning on the toilet as well. We're also going to talk a little bit about using interferential current to help with slow colonic transit. I have my slide coming up. Here has some animations. So we see some bowel matter on the right lower quadrant, just in the ascending colon. And these 2 pieces of bowel matter are going to move at different speeds here. And so normal colonic transit is about 24 hours or to 72 hours. Anything, if you eat something and it takes more than 3 days to show up in your stool, we consider that slow colonic transit or slow gastric transit. And so some of the things that we are trying to do is the goal to help move that stool more quickly through the colon, because if it moves more quickly through the colon, it is less dried out. We talked about sleep, movement, and massage when people eat their meal, and then positioning. So generally, although bowel massage can be helpful at any time of the day, if people typically have their bowel movement in the morning, doing the bowel massage when people wake up is a good time to do it. This should take about 10 to 15 minutes, 5 to 10 times each of the strokes that I'm going to show you here. You may do an internet search and see different descriptions of bowel massage. There has never been a comparison of type A bowel massage, type B bowel massage to say that one is better than the other. Most times people are lying down. They shouldn't have recently had a meal, so those are important variables. There is probably a lot about the mood that is happening during the bowel massage. So simply, oops, went too fast. Sometimes just holding the hands over the left lower quadrant in the area of the sigmoid colon. And I did this with a person today who has a lot of type 1 Bristol stool chart stool. And I was just holding here and kind of moving toward the umbilicus. And after about 2 minutes, she had some bowel activity. So we stimulated some peristalsis. From there, we'll just do some gentle strokes. I think of it as the letter J, going from the anterior superior iliac spine toward the pubic bone, along the sigmoid colon. Hopefully you can see my arrow moving. Then we'll add in the descending colon to the sigmoid colon, descending colon, sigmoid colon, and repeat that. Then we'll add in the transverse colon, descending, sigmoid, do that stroke. And then we'll add in the ascending colon, transverse colon, descending colon, and sigmoid. And then it almost becomes that you're making a full circle here. The way that massage kind of looking layered, again, sigmoid colon, descending and sigmoid, transverse descending sigmoid, then ascending, transverse, descending sigmoid. Hopefully that was a good learning tool. While still in bed, again, people can go through 30 seconds of each of these stretches. So lower trunk rotation in each direction, one knee to chest, other knee to chest, both knees to chest. So it might look like this sequence. So that will take about 2.5, 3 minutes. It could also be done in seated, right? It could also be done in standing. So they're doing this, they're waking, they're doing the massage, they're going through some of the movement. They're going to eat a really healthy breakfast. Then they're going to sit on the toilet. And sometimes if people are slouched on the toilet, we recommend something called a squatty potty or a stool here. We want people to be relaxed. We want their breathing to be relaxed, and we want them to be safe on the toilet. And that's how we're trying to optimize bowel function for people who have constipation. When talking about modalities for constipation, you can do the same TENS that you saw me talk about earlier and that people learned when they were here. And then there's also something called interferential current. So there's the TENS, again, showing the common placement and why it matters. And then with the interferential current, I'm assuming a certain knowledge base of modalities, but interferential current is a form of electrical current that is generally considered medium frequency. There's a carrier current that is usually around 4,000 or 5,000, sometimes 2,000 hertz. And then there's another current imposed on that that might be 4,080 hertz to 4,150 hertz. And in English, the word interferential comes from the word interference, and there is an interference current created in the abdominal cavity that affects the pacemaker cells of the colon and or the nerves to the colon and stimulates peristalsis in the abdomen. And this is the way it is commonly done, with electrodes at the level of the umbilicus, paraumbilical and paraspinal, and on either side, but it is essential that they cross. Sometimes electrodes on the back are difficult for people. The electrodes can also be crossed on the front of the abdomen, but it is essential that they cross. I became interested and aware of interferential current about 8 years ago when I started seeing more children who had problems with constipation, but I use it in both my pediatric and adult population. I make sure it's safe. Those same things about pacemaker and pregnancy and cancer will apply. And I am encouraging them to get a home unit. So this is something that they can do at home for themselves. So it is safe and it is low cost. And it has some small studies that show it increases the number of bowel movements per week. So in summary, when I talk about bowel and bladder function, we talked about food, we talked about the importance of movement, and also mood will influence those things. When you're thinking about helping people with bowel and bladder disorders or asking some of your patients, do they have these disorders? Remember, education and self-care should be the foundation of your treatment. There's a lot you can do with musculoskeletal and movement strategies. You can teach them bowel massage that is really easily integrated into a home program. And you have some electrotherapy modalities that are inexpensive and can be applied. And if you're, like really eager to know more, then additional class work that is days long, with EMG biofeedback and manual therapy for the pelvic floor. I'm a big proponent of exercise. And so I like to end with this. Okay, Connie?
Yeah, can you talk a little bit about somebody that's hospitalized and hasn't been moving as much?
Mm-hmm. Mm-hmm. Yeah, like they're on bed rest.
Well, or they're in bed.
Okay. Yeah. So I would focus on, now I don't know what your other training is. So with breathing exercises, we tend to say diaphragmatic breathing. And when we say that, what we're really meaning is we let the abdominal muscles expand with the inhalation. So a non-pregnant person might look pregnant on the inhale because there's so much belly expanding. And then when we exhale, we encourage them to draw their abdomen in. I'm going to go back a couple of slides. So focusing on slow, purposeful inhalation. Sorry, the way this shows it can be helpful because that is mobilizing the abdominal cavity. We tend to think of breathing as a thoracic cavity activity, but it also can involve the abdominal cavity. So you can focus on a deep abdominal inhale and then a full exhalation where the abdominal muscles are active. So here I just showed it in kind of a single dimension. I showed the respiratory diaphragm going up as the pelvic floor came up, and then the respiratory diaphragm goes down as the pelvic floor goes down. But where this gentleman's hands are, his hands could also be going in towards the spine. And so that is how you could use like a full abdominal expansion, abdominal contraction breathing on that exhale. There is something else called paradoxical breathing. So paradoxical is opposite breathing, where when you inhale, the respiratory diaphragm comes down and you also contract your abdominal muscles. And so that compression from the respiratory diaphragm coming down and the abdominal muscles coming in helps to massage the colon and abdominal contents in that way. And then when people exhale, you have them expand their abdomen while they're exhaling, and that releases a lot of that pressure. So it is paradoxical. It is something that people need to practice, but there are ways you can use breathing to affect the abdominal cavity and the abdominal organs. You can do the bowel massage as well and teach the person to do the bowel massage for somebody who is on, who has been inactive in bed. And I would imagine that they're also on some stool softeners, and hopefully they're being assisted to the toilet. It is to sit and have a bowel movement. I assume that question was more about bowels. Does that help?
Yes, thank you. I just think a lot of times just the person's body changes when they're an inpatient.
May I ask?
Yes.
The technique that you said that we need to practice because it's a paradoxic movement. Can we facilitate the patient that are bedridden to do that in bed? And what position in bed to facilitate best?
Again, I almost always start with people lying on their back, and I will cue with my hands or their hands. So putting their hand on the sternum, so in here, so you or they are monitoring what's happening in the rib cage, and then have another hand on the abdomen. And then if that is not working, side lying can be another position, because the abdomen will can kind of sag out, and it has to work against gravity in side lying a little bit. And you can also palpate on this lateral costal area. So you can cue them to, keep your ribs together while you're inhaling. We're only filling the belly. Let the belly fill like a big balloon. Okay. And then when they're exhaling, oh gosh, I think I just said that wrong because we're talking about paradoxical. So when they're inhaling, you can cue them to inhale into their rib cage. You can be on the sternum, you can be on the lateral costal area, and really, really feel into my hands and pull your belly in. So they're getting a lot of thoracic expansion and they're getting abdominal compression. And then on the exhale, you can move your hand to their belly and really say like, okay, exhale, but push your belly out. And they will have to change their thoracic cavity. It's a great way to improve thoracic expansion and improve breathing in general, although that is not the focus of this talk. I would say practice it on yourself first. Like you all could, just sitting here, think about taking a breath in and pulling your belly in, and then breathing out and letting your belly sag, and breathe in, pull your belly in, and breathe out and let your belly out. And if you're thinking to yourself, that feels backwards, yes, that's why it is. It's paradoxical or opposite breathing. But humans benefit from learning to do things in multiple ways.
Did that answer Dr. Sushila?
Yes, thank you. Very difficult because it's opposite the normal breathing that I teach the patient.
Yeah. Right. And so like the question was, person on bed rest, maybe with some bowel dysfunction, how can we alter the abdominal cavity? Because my sense was that you were concerned, well, I'm not going to have them really twist, and I'm not going to have them twist, and I'm not going to have them bring their knee up to their chest. So I directed it towards something different. And I mean, I wouldn't, breathing at all is good. Right and wrong, when we put that on breathing, maybe that's not our best terminology. Anything else?
Do you know that, Sandy, that in the hospital setting, we have more discharge delays because the person has not had a bowel movement.
Did not know that. And so this bowel massage could be really helpful in the exercises.
Dr. Sushila, did you have another question?
Okay, Connie, I have a question from
Okay,
Tan.
Mr. Tan.
Yep. For the aging, I know that breathing exercise or control the pelvic floor is quite difficult. In my experience, that if the aging, when they breathing exercise, the control of the exercise or control the pelvic floor is quite difficult. In your experience, does it have the problems when you tell them how to control the pelvic floor or how to control the breathing exercise during together or not? Could you please share the experience?
Okay, I think I understand the question. So I'm going to answer the question that I think that you're asking, and I hope that I am correct. So because I've been a pelvic health therapist since 1997, I do internal vaginal exams and internal rectal exams to measure people's strength and their ability to contract the muscles and their ability to relax their muscles. This is all with consent and permission and education. And I, throughout my career, have looked at different ways to help people get the best pelvic floor contraction. Adduct your hips, externally rotate your hips, like while they're on the table and I'm doing the activities, curl your toes, right? And I will have people exhale, like I described to you in this exercise, like exhale, making a shh sound like that. And so I cue them, squeeze around my finger, and exhale, making that SH sound, or exhale through the straw. People get a better pelvic floor contraction when the pelvic floor muscles have something to do. It is not the only way to get a better pelvic floor contraction. There are vaginal weights that people can use. There's the EMG biofeedback, so they can see it. I can tap with my finger to kind of like cue the muscle to work. But since my goal is that they have a good home program, that they're getting their best pelvic floor contraction, coordinating it with the breathing and making that sound has been one of the most helpful things. And I would say that lots of exercises when you're trying to teach people to use their pelvic floor and you can't see it or touch it or know what's happening are difficult to cue, because we teach movement so much as therapists by like, we show people what we want them to do, but we don't show people how to do this. We have to really connect with their kinesthetic sense, and we have to have lots of verbal and visual cues of what's happening. Did I answer the question or?
One of thing that you showed me is that biofeedback by touching or with another equipment, right? Like an EMG or biofeedback with the machine. Okay, for the machine, maybe it's not difficult for us. And touching, be difficult for the therapists who are the men with the women.
Sure. Yeah, which is why we didn't focus on that particular part. We focused on all the things you could do outside of doing that. So if you're, so I'm going to back up, right? You have a patient, they told you they leak urine, and it's with coughing and sneezing and lifting a heavy box. They just had a baby 6 weeks ago. And you're like, I'm not going to look at this person. I'm not going to touch their pelvic floor. You know, I'm going to teach them this exercise with breathing. I'm going to have them put their hands on their low belly, maybe have them sit on a rolled towel under the perineum, and I'm going to cue them to exhale with that sound and feel their lower abdomen go in. And we know that the transverse abdominis muscle works often in conjunction with the pelvic floor muscle. And you're going to make sure they don't slump their posture and make sure they don't tense every muscle. And you're going to say, I want you to do this 20 times a day. I want you to do 4 sets of 5 reps. I want you to do them really well. And when they come back in 2 weeks or in 4 weeks and 6 weeks, remember we said 6 weeks is when people will see improvement. And if they've improved their stress urinary incontinence without you looking at their pelvic floor, I would call that a win.
Okay, thank you very much for a physical therapist who are the man.
Okay, here's a question in the chat.
Okay.
Could you recommend an outcome measurement to monitor patient with incontinence to track the progress after training?
There's the ICIQ short form. And that's an international form. You have to get permission to use it, but they grant permission really easily. And then there is another form called the PFDI, which is pelvic floor distress inventory. And it has prolapse, bowel, and bladder questions, 20 of them, 6, 8, and 6. And then there's one that I don't use commonly, but I do like. It's called the PFIQ, which is pelvic floor impact questionnaire. And that one asks about activity and leakage, and activity and prolapse, and activity and bowel function. Are you typing that in, Connie, or should I like open the chat in some way?
Actually, no, actually I've written them down, but could you send me the link to
Sure.
them? That would be great. And I would include it with your presentation
Okay.
when you send your presentation.
Oh, I think I already sent the PDF of the presentation.
Oh, you want me to send that one? Okay, perfect.
Oh, okay.
So
But I will send the other questions.
yeah, so the first one was ICIT short form.
ICIQ.
IQ. And then PFDI inventory, and then PFID questionnaire.
Nope. PFDI, pelvic floor distress inventory. That's that one. And then the PFIQ is pelvic floor impact questionnaire.
Right.
Yeah.
So if you can just send me the links, I can send them on.
I'll fix it.
I think we are over time by 5 minutes, Sandy. Imagine you are my last speaker.
I know. I just was like, I didn't know that.
Yeah. No, the budget just came in. And so thank you. Dr. Sushila Tan, anything to add?
Can people turn on their cameras if I met you this summer, fall? Like, I think they're.
Well, Sinisa, it was the one that was virtual that you would know for sure.
Okay, yeah.
And yeah, there's quite a few.
Yeah, okay.
But I think we're over time and we have to let everyone go. We had 61 participants tonight.
All right.
But Sandy, thank you as always.
You're welcome.
Amazing. I learn every time I hear you talk. I learn something that will benefit me in my life.
Okay, thanks.
Dr. Sushila put a thumbs up and clapping, and so did,
thank you.
So did Tan. Thank you, everyone. Is there anybody that wants to say anything else?